All right, let's talk about our cardiovascular drugs. So we have a whole bunch of different topics that we're going to be covering. When we think about cardiovascular drugs, I want you to understand that because there's so many different types of things that can happen with the cardiovascular system, that we may be talking about one set of medications for hypertension, and then we may talk about that same set of medications again when we talk about dysrhythmias or medications for a heart attack. They all kind of are combined and interwoven together. So let's talk about our first ones. So our first one we want to kind of talk about are going to be where it all kind of comes down and it starts. And that's really and truly, it's going to be our drugs for our lipid disorders, because our lipid disorders are the foundations that kind of begin this whole process of having cardiovascular disease for us. And it actually starts at a pretty young age. We have two different types of cholesterol that we always worry about. It's the cholesterol that you eat, and then also the cholesterol kind of chemical makeup or genetic makeup that you have in your life based upon your parents, based upon your genetics, okay? Sorry, still trying to get everything right here. So when we're looking at cholesterol, one of the things that we always think about first is we think about the levels of cholesterol. So whenever someone comes into the clinic or to see their PCP and they get their cholesterol drawn, we're looking for two different numbers. We're looking for what their total cholesterol is, the big number whenever we add both of these up, which is their LDL and their HDL. So what happens is when the body takes on food, or basically just in the structure of your cells, you've got to have cholesterol. So in your body, there's something called the VLDL, which is your very low density lipoproteins. And basically what this guy's job is to go around and to help your body and to deliver triglycerides in your body. But when it degrades down into its basic substance, it turns into LDL, okay? Now the LDL is kind of like a delivery truck. It has like a big, huge truck, and he drives around and he has all this cholesterol in the back. And Bubba's job is to deliver the cholesterol wherever it needs to be for cellular function, to build cell walls, you name it, he's going to be a man and get it there. However, sometimes we overload Bubba's truck with cholesterol. Now, Bubba wants to be seen as a good driver and a good delivery man, so he doesn't want to bring back any extra product. So sometimes what Bubba does is, as he's driving through your cells and driving through your body and your arteries and your veins and stuff, he's like, oh, I got extra crap on my truck. Oh, get rid of it. And he does. He just dumps it off anywheres. Well, that dumping off of that extra stuff, of that extra cholesterol, is what begins to build plaques in your arteries, in your artery walls as it goes through. Now your HDL, these are the ones who come along and they're like, this cholesterol doesn't belong here. And so it scoops up the cholesterol, puts it onto its truck, and then heads on down over to the body, to the liver, where it says, hey, I have extra storage for you. Can you please take this? And yes, thank you for returning our product. We really appreciate that. So our big issue here, or a lot of our therapies that we're talking about today, are the ones that are going to lower our LDL levels. Here's a picture of a coronary artery. Guys, this coronary artery is not right. That coronary artery lumen has got a lot of cholesterol building. I'm running my mouse. Actually, let me grab a color here. This out here is supposed to be the lumen wall. Okay, way out here. This is obviously someone who's died. All that in there, all that inside that circle, that's all cholesterol buildup. Okay, it's been laid down in there for years and years and years until it finally caused an occlusion. Now, this is a coronary artery, so it can happen in the heart, but we can have that same effect happen in any of our arteries. It can happen in the femoral, it can happen in the aorta, it can happen in the brain. Okay, all of these lead to a narrowing of the blood vessel. Those narrowing of the blood vessels is what we will see as nurses to be manifested as strokes, heart attacks, blood clots, people who have an occluded artery or a vein in their leg. So when do we want to start screening patients? It's always about health. We should be thinking always about how to keep our patients their healthiest. Well, if the American Academy of Pediatrics had their choice, we would start to actually monitor everyone starting at age 2. So at 2 years of age, we would bring patients in and we would begin to draw their blood and see what their cholesterol levels is. The reason why they wanted to do that is because there is a genetic condition that predisposes children to having very high cholesterol. And if we can catch them early enough, then we can prevent premature death, like premature death as in like 30s, 40s, and 50s from coronary artery events. So I will tell you that it's pretty hard to convince a mama that we need to check their child's cholesterol at age 2 because they all believe that there's no possible way that this child could have high cholesterol. However, children frequently ask for a Happy Meal or McDonald's. So what's mom feeding them? Are they on a good diet that could have prevented that, or because of the American diet, or is this patient really at risk? So what we want to do is we want to definitely start screening them by age 8 to 10. If we can hold off, wait till age 8 or 10, start it then. We'll try again. Okay, but again, convincing a child to get a blood test can be a little bit of a complication, and especially for something that no one feels bad about. Like if you're running around with high cholesterol, you're not going to be like, oh my gosh, my head always hurts. It's because of my cholesterol. That's not what we say. We don't feel bad because our cholesterols are elevated. But absolutely, no matter what, we're going to start screening you at least by age 20. Welcome to adulthood. Let's start screening you for cholesterol and looking to see where they're at. Again, this is a preventative measure. If we start screening early and we continue to screen, and then we use the appropriate guidelines, there could be a chance that we could decrease this person's risk of a heart attack, a stroke, blood clots, a lot of bad things. So once you start at age 20, then they're going to look at it 1 to every 5 years, and it's really dependent upon your primary care physician and the discussion with the patient about what they want. So here's the absolute treatment guidelines. If a person has any of the following, they absolutely need to be on a cholesterol lowering agent. So we talk about adults who have atherosclerotic, cardiovascular disease. So any of those adults who have a history of an MI or have a history of any kind of coronary artery events need to be on a statin drug. This is typically where whenever we're listening to the primary care physician who's getting information from the patient, they'll say to them stuff like, so did anyone in your family ever have a major cardiac event before age 50? And if the answer is yes, then that could mean that from a genetic standpoint, that patient is more at risk for developing coronary artery disease or having some sort of a cardiovascular or an atherosclerotic event. So we want to watch them more closely and offer them statin therapy. Any patient who has diabetes mellitus, who is age 40 to 75 with their LDLs of 70 to 189, statin therapy. Adults with LDL levels greater than 190, statin therapy. Any adults who are 40 to 75, LDL 70 to 180, and have a 7.5% greater or risk of an atherosclerotic cardiovascular event needs to be on a statin therapy. I provided you a link here. If you click on the little tab right here, what you're going to find is it's a shout out to a website where you can go in and you can actually calculate out your, sorry, I get talk. I need more coffee. That's what it is. Atherosclerotic event, cardiovascular disease calculator, and you put in a whole bunch of numbers there. I will tell you that on an ASCVD risk calculator, one of the things that you absolutely need to have is you actually have to have your cholesterol levels sitting in front of you. So for those of you who have never had your cholesterol drawn and you're greater than age 20, it's time to go get it done. You can get it done at Walmart, Walgreens, your favorite pharmacy. They usually have little cholesterol kits, or you can go see your primary care physician, which I highly recommend, so that you can have that discussion with them. So, next slide. On this cardiovascular risk disease, this is just things I want you to think about. Whenever we see these patients running around our community, this puts them at more risk for these cardiac events. So anytime that a patient has a family history, or I talked about hypertension, cigarette smoking, I cannot find a good reason for anyone to smoke cigarettes. I've tried, okay? So convincing the patient that they need to do that. Any patients who have not a low LDL, but high LDL, if they have C-reactive protein levels that are elevated, C-reactive protein is a lab test that we can do on patients that shows determines their amount of inflammation in their body. If that level is really high, then with that patient, we need to be sure that we are putting them on a statin therapy drug. And then that way we can make sure that that inflammation isn't causing scarring of all of their arterioles and veins in their body, because otherwise that can lead to long-term damage. And then of course, diabetes. This is an old study, how we calculate 10-year risk. There are some 10-year cardiovascular risk assessment tools. ASCVD is pretty much, we kind of replace those, but you may still see a couple of 10-year risk out there. And of course, again, just kind of going over that again. Okay, this is the main reason why we're here today. We're here to help this man. His name is Chuck. Chuck comes to us today. He's a grad student at Texas A&M University, and he has decided that it is time for him to take responsibility for his health care, and he's coming today for a well check. Good job, Chuck. Fantastic. Love to see it, Chuck. Okay, so his initial blood pressure in the office, 139/89. Blood pressure pulse is 86, respiratory rate's 12. We draw his lab work, and his total fasting cholesterol is 240. His LDL is 189, and his HDL is 35, and his triglycerides are 199. So what do you think about Chuck? What drugs do you think he needs? And then what do you think we can do to help him, convince him that he needs to do better? Let's talk. So, of course, with any patient who comes in for anything in medicine, we always want to start with this non-pharmacological interventions before we jump into the pharmacology bandwagon, right? So there's a couple of things that we can have Chuck do today that are going to make him feel much better and that may potentially help to prevent him from needing long-term medication therapy, right? So number one, we want him to decrease his fat intake to less than 35% per day. We don't want him to go cray-cray and like eat no fats whatsoever, because what we found is when we put patients on a no-fat diet, then we had this huge rebound spike in their cholesterol. Wait, what? Why? If you don't eat fat, then why does your body all of a sudden go crazy and have like this really high cholesterol level? What we found is what we forgot to take into account with these patients is that when we need cholesterol, we got to have it. We got to have it to build cells. We got to have it to do good things in our body. When you don't have cholesterol, your body then says, well, I guess we're going to need to make more of it. And so your body does. It begins to take things from other parts of the body and make more cholesterol, which then causes the LDL levels to actually rise. We need the patient to eat less unrefined, I should say unrefined carbohydrates, or refined, I guess it's refined carbohydrates. So it's anything that's processed, okay? Any of those carbohydrates that you can rip open from a bag and eat, less of those. No trans fatty acids, and we want him to increase something called plant sterols in his daily habit. We can get those in the form of a drink. Sometimes they're butter. Some of the products that we can buy over the counter actually have an increased amount of plant sterols. We want weight control. We want exercise. And then absolutely, we want him to eliminate tobacco if he's already on it. So very, very important that we can get him to do these non-pharmacological interventions in addition to our medication therapy, or in lieu of, we might can get somewhere with his cholesterol. But just in case that this non-pharmacological intervention doesn't work, then what we're going to do is we're going to talk about our drugs next. Hands down, bet the farm on it. Statin drugs are the #1 therapy to help to decrease cholesterol in a patient of any age. These other ones should be thought of as adjuncts to or in addition to, or if the patient absolutely cannot tolerate a statin drug. We do have a couple of different patients that absolutely, positively cannot tolerate statins. They've tried every one, they've tried every brand, they've tried every brand name, they tried 1 pill, 2 pills, no pill. It just doesn't work for them, okay? Because of the side effects of the therapy, or the side effects of the therapy. So, but we will do our best to start with lifestyle modifications in addition to this. And again, typically the #1 treatment for anything with cholesterol is going to be a statin drug. So here's the most popular statins on the market. We got atorvastatin, fluvastatin, lovastatin, pravastatin, rovastatin, and simvastatin. With these medications, we do get up to a 50% reduction in cholesterol. These names, their brand names probably will sound pretty familiar. I will say that most of these medications have been out long enough that their brand names have kind of gone dormant. and we really don't hear people say those. They've gotten into the habit of saying rovastatin, lovastatin, pravastatin, simvastatin. I don't see a lot of fluvastatin out there anymore, not in this region, but you may see it out there wherever you are. I will tell you that typically with these medications, we used to see a lot of commercials on TV for these. All these medications, it is possible for you to jump on YouTube or onto the Wide Wide World and actually go to the brand name, and they'll have their own website. Sometimes they provide educational videos, they provide additional information about their drugs. So I like them. A lot of these medications have even moved to the $4 and $5 list at our local pharmacies, which is super helpful. You know, used to when they first came out, it was like $85, $90, $100, $200, $300 a month to control your cholesterol. Now it's dirt cheap. Take your medicine. With this medication, we can expect up to a 50% reduction in cholesterol. So we get a pretty good bang for our buck here. You know, $4 a month and a 50% reduction on my cholesterol. You betcha. Every day of the week. All right. So with our statins, how do they do it? So what happens is that remember the LDL is responsible for removing cholesterol from the blood. Well, what these medicines do is they help to interrupt the cholesterol synthesis. So we don't have as much cholesterol running around. So because we don't have as much cholesterol running around, the body actually says, let's make more LDL receptors to catch whatever cholesterol happens to be floating around, okay? So what it does is it actually creates more delivery trucks, and it grabs more of the cholesterol floating around and then holds on to it so that we can actually deliver it to the cells where it needs. Most of the time, we get pretty good therapy with this medication. The only problem that we have is that there is some groups of people that just absolutely can't tolerate it. So we may have to use other therapies for them. One of the cool things that we found out about statins after we were giving them out is that they actually help to provide plaque stability, okay? So I have a little a sticky notepad here in front of me, and you can see it's all kind of in layers. Well, when cholesterol is laid down inside the arteries, it kind of comes out in layers like this too. So what the statin drug helps to do is that, you know, because this is a layer, there's a propensity for pieces of it to, you know, fall off. Well, what a statin drug helps to do is that it helps to stabilize the plaque so that it does not float off or binge off or go and run around and get into something that it's not supposed to. So it kind of helps to suppress inflammation, okay? And then it helps these plaques to kind of become more stable so they're not constantly peeling off and running around the body causing issues. So that's what a statin drug essentially does. And it helps to collect more of these cholesterol. It helps to collect more of the cholesterol that's running around, okay? So very important that we do that. The other thing it does is that, you know, with the plaque, it's going to help it to keep from peeling off, but it's going to help to prevent it too from not becoming a block or becoming calcified, becoming really, really hard, because we want elasticity in our veins and our arteries so that they can increase and decrease. So it helps to kind of slow that calcification process down so that we still have that elasticity in our arteries. Patients who are put on statin therapy, once we get them stabilized and on the drug of choice, they're going to be on it for life. We don't want these patients to come off of this medication unless there is a good cause, because patients who come off their statin therapy are at risk for an atherosclerotic event. Again, a lot of different therapeutic uses. We want to see these on all of our patients who've ever had a cardiovascular event. We want to see these on our patients who are status post-MI. Okay, look, if I had a choice, you're like, okay, when would I really want a person to start on statin? It's before the cardiac event ever happened. Okay, but we kind of use it as a better late than never kind of a process. Diabetic patients, because the diabetes causes an inflammation in their body, the statins help. They help to prevent this patient from having a future ASCVD event. Here's the bad side. So these medications can be pretty hepatotoxic. So we bring the patients in, and when we're looking at when we're looking at labs that have to do with the liver, we're looking for two specific ones. What are they? AST and ALT. So we look at those numbers. If the AST and the ALT begin to rise and they go to 3 times the upper limits of normal, then we may need to take the patient off of their statin drug, okay? Another one of the crazy things that happens with patients who are having statin drugs is that they'll develop muscular pain. When they develop this muscular pain, it can be pretty debilitating to them. So we tell them it's a short-term effect. If it's still continuing and interfering with their activities of daily life, we'll either switch the statin drug or we'll give a supplement, and we'll talk more about that supplement later. The other thing that can happen with statin drugs is if that myopathy goes too far and it's continuing, they can actually develop something called rhabdomyolysis, which is basically a breakdown of the myofibers of the muscle that are really, really big, and then the body tries to take care of that and tries to get rid of them via the renal system. The problem is that those myoglobin fibers, when they're broken down, they're huge, so they can't get through the kidneys, and then they clog the kidneys, and then the patient goes into renal failure. So we do pay attention to the myopathy. We correct it if we possibly can. If we can't correct the myopathy, then we either switch their statin to a low intensity, or we may have to do something different, a lower dose, every other day dosing. Again, trying to keep them on their statin, but also manage the side effects. A lot of times at nighttime, you're processing through your cholesterol. So because of that, we tend to like all of our patients to take their statin drugs in the evening, okay? There are 2 medications that don't have to be taken in the evening because they have a longer action. However, I say for the sake of just remember to take everything in the evening, the statin drugs in the evening, and it will help. Sometimes when a patient comes in and they've got this horrible cholesterol, we try the statin and we're not getting where we want fast enough, so we'll add another agent on top of that. You can't get too much of a good thing. We don't want your cholesterol to be at 0. We need the Goldilocks principle. Not too much, not too little, but just right, okay? And that's really how your body works. So if we start adding other agents, the other agents on this list, the bile sequestriants, the nicotinic acid, all those, we need to be thinking about the balance of the cholesterol, the balance of the triglycerides. There are a couple medications and things that you should never mix together. Those include your macrolides, antifungals, fibric acid agents, immunosuppressant agents. We really don't want to put these together. The fibric acid agents, it's more because the cumulative effects of the statin and this one together can really cause a lot of problems. It's not because of a direct drug interaction. Grapefruit is the devil fruit in pharmacology, okay? Grapefruit has a tendency to cause medications to go to a toxic level really, really fast, which is a huge problem. Every little old person I know in the month of June is like sucking down grapefruits that are like, the size of my head. They're like, and next thing you know, they're all toxic on all their medications. So they can eat their grapefruit. It just doesn't need to be at every single meal, and it needs to be within a limited consumption. Again, be careful. Grapefruit juice is in a lot of things that you wouldn't think it would be in. Asian patients. So Asian patients, because of their diets, 1, tend to have really good cholesterol levels, but 2, sometimes they are just not able to tolerate the way that their bodies are structured. It has something to do with their liver and one of their hepatic enzymes. They're not able to tolerate a statin drug at all. So don't be surprised if the patient with an Asian patient comes in and they weren't able to tolerate it. Any patient who has renal impairment, again, we got to be careful because they may not be filtering all that drug out. Okay, so I told you there's a supplement that you can take that sometimes helps with statin drugs. It's called CoQ enzyme 10. So over the counter in your local pharmacy right now, we will frequently recommend patients to take CoQ enzyme 10 at the same time as they take their statin drugs. The benefit is that those patients tend to not have the myopathies that are associated with the statin drugs. Now, why in the world, I don't know why they don't make this a combination medication. I don't understand, but I'm not a chemist. Here is a couple of charts. I just want to show you that based upon the type of statin that we choose, we get more bang for our buck. So we have things that are called high intensity statins, moderate intensity, and then low intensity statins. So what the primary care providers know is that based upon how high the cholesterol is, it's really going to help to dictate to us which one of these that your patient could be on. So you can kind of see here too, like what the change that you would expect to see in the cholesterol as a whole, the LDLs, the triglycerides. It just kind of gives you a little chart. Again, it's helpful to see. So typically if a patient comes in and they have a mild to moderate high cholesterol, we would start them on a low intensity statin. And then if we didn't get anywhere, then we would go to a moderate intensity. And then they were like, oh my gosh, we don't do this right away, then we go to a high intensity. And we've been known to modulate up, okay, or come back down depending on what the patient needs. So sometimes a statin alone just doesn't cut it. So what we do is that we take the bile acids and we add them to the statin and we get about a 20% drop in cholesterol. So I call this the backdoor method of decreasing LDL because literally it goes into the bowel and it sequesters the bad cholesterol and it helps to get rid of it by you poop it out the back door. So again, a great medication to put into combination with. Before we had statin drugs, this was pretty much the only thing we had to offer patients. So again, worked okay. The biggest thing that we had was that didn't have a lot of systemic effects, but it did cause a lot of bloating and a lot of farting. And then we found that it kind of interfered with the absorption of fat-soluble vitamins, which is okay in some patient populations, but in our elderly or those who are very emaciated or catacaxic, this can be a huge issue. There's a couple of medications that it does not play well with. Again, I think about our patients who are taking these taking this lipid medication. Most of them are also taking these cardiac medications, and it's a little mind-boggling to go, oh my goodness, all of your medicines are going to interact. Are you going to be okay? I think I'm always amazed as a nurse when I look at a patient's medication list, and I'm like, you're taking all this, and you're still alive? Okay. Sorry, so that was our bile acid sequestrants. Here's our next one. Our next one is called nicotinic acid. So fun thing about nicotinic acid is patients with triglycerides tend to take this one quite frequently. Nicotinic acid has a horrible flush effect. So one night we were working in the emergency department and one of the charge nurses, who should not be named, took his medicine. It took the medicine, and when he took the medicine, all of a sudden comes out of a room and is just from head to toe, looks like he'd been in the sun for hours, just red and flushing and just looked horrible. I mean, just looked bad. What he did not know that he should have known was that before you take nicotinic acid, at least 30 minutes before, you take an aspirin with it. You take an aspirin with it, then take the medication, and then you won't get the horrible flushing. So very important that they take the aspirin and then take the medication. I will say that people do tend to build up that once they've been on nicotinic acid or Nispan for a couple of months, that the flushing is not as bad. It gets better as it goes along, but in the beginning, aspirin 30 minutes before and then take the medication. Works really well to help to decrease triglyceride levels and increase the LDL, but again, it can have a nasty side effect. Fibrates is another one of those medications that you'll see. I feel like I don't see fibrates out in the population of people that I'm treating very often anymore. I felt like 20 years ago I saw them all the time, but for the most part, I don't see a terrible amount of them. I do see some, but not a lot. With this medication, it can actually kind of backfire on us a little bit because it can work too well and then actually cause the body to make more LDL, more cholesterol in the body. And so because it makes more cholesterol in the body, we start to see an increase in the amount of LDL, which is completely and totally counterintuitive what we want to do. So these patients we have to monitor. Here's your side effects of your fibrates. Again, some of the side effects are the same here as they were with our statin drugs. With this medication, whenever we take patients that are taking both a fibrate and warfarin, which is also known as Coumadin, warfarin Coumadin / is a anticoagulant. It keeps the blood from sticking together. And so because of that, warfarin is a highly protein-bound drug. So when we give a highly protein-bound drug to a drug that has less of a protein-bound effect, it'll knock it off, right? And then we get an increased therapeutic effect of that drug because of the protein binding. So just to let you know that fibrate is warfarin is a highly protein-bound drug, and anytime it comes around, it's going to knock anyone off that protein bus. Here's your fun little slide all about lipids and gemcitabine. So our cholesterol absorption inhibitors, aka Estimbia, also known as Zetia, when this medication first came out, it was actually marketed to be a solo drug. We thought we had hit the mark. We're like, you know what, statin caused all those nasty side effects. Let's just keep the cholesterol from getting into the body. So again, get another new medication that basically prevents cholesterol from being absorbed along the GI tract. Well, that backfired on us. And what we found is that we would block the cholesterol, but then the liver would jump in and say, hey, wait a minute, I don't have enough cholesterol in here. So then it would start to produce more cholesterol. So what we found is that we took the Estimbia and then put it with one of our statin drugs. It actually gave us a better, more therapeutic effect for cholesterol control. Okay. So typically, don't see this one solo anymore. It's hanging out with the statin drug. Nasal pharyngitis, muscle pain, upper respiratory infections, bones kind of aching, diarrhea. These are all kind of the side effects of our Estimbia or our cholesterol inhibitors. There are a couple of other weird cholesterol disorders that are out there that your book kind of gleans over. I just want to let you know that both of these tend to be genetic in nature, and they do cause a pretty significant high cholesterol. We have some great drugs out there that help these patients, because some of these patients, because their cholesterols were so high, they were having an atherosclerotic event prior to the age of 50. So these medications, very costly, unfortunately. These patients tend to not respond to a statin drug at all. So you're watching that cholesterol and it'll be just outrageous. Over 300, you're like, what's going on? This patient looks so good. And it could be because of one of these weird, rare genetic diseases. We do have a really cool device out there called Repatha. Repatha, it literally looks, it's about the size, it's about the size of a mouse, okay? And what it does is that for Repatha, they go in and then they will attach it to the skin, and you hold it and you press a button, you go 1, 2, 3, zip, and it feels like you kind of got stung by a bee. And then it's stuck to your skin with a piece of tape, and then it will administer the medication through like this little bitty plastic catheter, and they have to do that once every 2 weeks. So other things that are out there to help people with their triglyceride levels, or to help naturally resolve some of the cholesterol issues. Fish oil has been known to reduce triglycerides. They usually come in a fun pill, which I take a fish oil every day because I have cardiovascular risk factors. So they're usually pretty large. You can get some that are not this big. If you get those that are made from like krill oil, they're like a quarter of the size of this, but I was cheap and bought this one. So I tell people, if you ever find me that I've ever read that a nursing instructor choked to death, it's probably because of fish oil, because again, that's a pretty significant size pill. So I tell my patients that when they take these, that if they buy the cheap ones from the dollar store or the cheap ones from Walmart, that they can have a fishy aftertaste, like you belch fish all day long. So the ones that have krill oil in them, you tend not to belch. And then if you read on the actual package, it'll say something like no fishy aftertaste. If they get a cheap one for whatever reason, or it's causing that, the first thing I do is I tell them to take the whole bottle and put the bottle in the freezer. Okay, it's not going to affect the drug. But take that pill when it's frozen, and then poof, no more fishy aftertaste. All right. Plant sterols are the natural cholesterol gobblers. Okay. There's lots of products out there that you can read that says inhibits cholesterol absorption. The other product that people are doing to help reduce their cholesterol is good old Metamucil. That's right. Drink your fiber, people. Drinking your fiber seems to help to remove some of the cholesterol from our diet. CoQ enzyme 10, we already talked about how wonderful that is as a supplement for patients who are having those myopathies associated with the statins. And then don't forget about red yeast rice. So red yeast rice is a organic compound that is produced, which is basically where we got our structure simulation for chemists for our statin drugs. Okay, you used to could order it online. I don't know if you can yet or not. I'm pretty sure you can still buy it at Walmart, but check it out. The other thing you want to talk to your patients about, and I've alluded to this previously, is that you don't want them to abruptly quit taking their drugs for their cholesterol. Abruptly stopping to take these causes the reverse of everything good that was just happening. So plaque stabilization, decrease clot or decrease inflammation. They'll have an increased spike in their cholesterol. All of a sudden, all their LDL trucks are just like dumping all of their cholesterol everywhere that they want to. So it's important that they don't abruptly stop taking the cholesterol medication. It is lifelong therapy. We do have to convince our patients that high cholesterol is something that has to be managed. Again, it's not like they have a bad side effect from it, a bad symptom. They're not like, yeah, man, my back's hurting all day long because of my high cholesterol. They don't feel bad. It's a silent killer. So helping them with their compliance is huge. All right, guys, see you on the next slide.